All right, well, let's go ahead and get started. Good afternoon, everyone. I'm Angie Murad. I'm a patient educator with the Mayo Clinic Cancer Education Program. I will be moderating this session. We're glad you are with us for this live webinar titled Supportive Oncology, the Role of Palliative Care for Patients with Cancer, presented by Dr. Richard Taylor. Dr. Taylor joined the Mayo Clinic staff in July of 2020. Currently, he's a senior associate consultant in the Department of Hematology, Oncology, and Palliative and Supportive Medicine. Since his arrival in 2020, Dr. Taylor has been actively involved in quality improvement for palliative care and the development of the Acute Care and Symptom Management Clinic for the Cancer Center at Mayo Clinic, Florida. He has also continued to grow the supportive oncology clinic in the Cancer Center on the Florida campus. His clinical interests include complex symptom management, along with communication and coordination of care for patients with cancer. He is board certified in hospice and palliative medicine and internal medicine. We want to let people on this webinar know today that we are recording this session, so individuals who are not able to join us for the live session can watch it later. For those of you who would like to view this webinar again, the recording takes about 3 days to be edited with our media services, and then we will put the video on our video library tab on our Mayo Clinic Cancer Education group on Mayo Clinic Connect. Mayo Clinic Connect is a digital platform where patients, family members, and caregivers can connect, get evidence-based information, and get access to information about classes that our center offers. We encourage you to follow the Cancer Education group on Mayo Clinic Connect so you can stay up to date on any upcoming webinars and other education opportunities we have. I'll put the link in the Mayo Clinic Connect Cancer Education group in the chat. But I'd also like to make a quick announcement of some upcoming webinars that are coming in February and March. Our topics include a webinar series on financial toxicity, managing the costs of cancer care, which will be presented by a Mayo Clinic patient navigator here in our Cancer Education Center and an oncology social worker. So there will be 3 of those webinars offered in February, those 3 Wednesdays in February. And then in March, we will offer Cancer and Stress presented by Dr. Janae Kirsch, who's a fellow in the Department of Psychology. So when I put on in the chat, remember to register for those sessions ahead of time so you can get signed up for those. All of the sessions are free. We will take questions at the end of this session. So if you have any questions related to this webinar topic, please type them in the chat function at the bottom of this Zoom screen. So I'm pleased to turn this presentation over to Dr. Taylor. Thank you.
Thank you, Ms. Murad, for that introduction. I'm going to switch over and get the presentation pulled up. We'll get going. Okay, hopefully you guys can see it now. So thanks for joining me this afternoon. I guess it's noon now in the Central Time. I'm here in Florida, and I appreciate the opportunity to speak with you guys on a topic that's near and dear to my heart. So supportive oncology is something that that I do here in the Cancer Center on the Florida campus, and it's a new term, relatively new term, I guess, for a lot of folks. And some of you may have heard it. Some of you may have heard palliative care. And so today's talk, we're going to dive into this a little bit. So we'll get started. So these are some learning objectives. Here they are that I would like to kind of go through. So we're going to talk about what is supportive oncology and palliative care. We're going to hopefully help folks understand the difference between palliative care and hospice. I jokingly tell patients in the clinic all the time, Dr. Google can get you in trouble because the first thing you see when you type in palliative care sometimes is hospice, but there are a lot of differences. And then we're going to describe some of the supportive care guidelines or highlight them that are on the National Comprehensive Cancer Network website. That's NCCN. So that's a a network that physicians use to help guide some of the treatments for cancer. And there are supportive care guidelines on that website. And then hopefully by the end, we'll also help folks recognize the importance of advanced care planning. So what is supportive oncology? So essentially it encompasses a lot of the other aspects of care, actually most of them, excluding the direct treatment for their cancer. So when you think about oncology and folks with cancer seeing their cancer doctor, really it's everything else but the chemo or the radiation and the labs and the scans, right? So there's a lot more to it. Really, the main focus is quality of life. The goal is to address some of the issues as early as we can in the diagnosis and not wait, and therefore have people with a poor quality of life throughout the process. So symptom management being high on the list, psychological and spiritual aspects of care, and then also specific to oncology, making sure we look at the potential side effects or adverse events that may be related to treatments. Here are some palliative care concepts, and this came from a webinar that I gave very similar for the myeloma folks. And essentially, we look at the whole person or the whole patient approach, right? So we're not just focused on one thing. We're looking at family and caregivers. Again, symptom management, you'll hear that pop up several times throughout today's talk. Nutrition, right? That's an important aspect. Supportive care and counseling, spiritual care, social support, and of course, last but not least, the coordination of care. And all of these fit in and kind of give us the whole person approach. So how is palliative care or supportive oncology, which are very similar, how are they different though from hospice? And there are some big topics that I think separate the two, or some highlights, I should say. The main one is actually the prognosis. So for hospice care, typically we think of a prognosis of less than 6 months for patients. But for supportive palliative care, it can be any time. I see patients with advanced disease, and I see patients that are early stage, or even potentially curative patients that still have symptoms related to their cancer. So it's any time. The other thing that separates the two is that under hospice care, typically doesn't allow for ongoing treatments for curative intent. However, for supportive care or palliative care, they go on at the same time. And so we're managing patients from a symptom standpoint, but they're still getting their curative treatments or palliative treatments. The other place is the location. Typically, hospice care happens at home, sometimes in hospice facilities, and then palliative care usually happens, at least for me, for my patients, in the clinic, or also in the hospital. And of course, in the middle, you can see things in common are some of the things we've talked about. So maximizing comfort, quality of life, reducing stress and symptoms. So I just like showing this slide because we've come a long way in the palliative care world or supportive oncology world. The old model used to be that people are getting their disease-directed care, which means that they're getting their treatments for heart disease, lung disease, cancer, you name it. And then if they get towards the end of their life, palliative care would come in for a short amount of time before the transition to hospice. And so that's how I feel like palliative care kind of got the, this is just end of life treatment, or this is just hospice, because that was the old model. And the new model, though, really palliative care can come in anytime, from the beginning of the diagnosis or in the middle. And we actually prefer it not be towards the end of someone's life. And so palliative care should be started early to maximize that quality of care. So the new model works a lot better for patients and family members and the hospital system too. So the National Comprehensive Cancer Network, I mentioned that in the objectives. They have a set of guidelines, and these guidelines help physicians make sure that we're giving the best care that we can. And those guidelines are specific to supportive care. And I'm just going to talk about a few of those. Cancer pain is, in my opinion, up on the top of the list. The next word, anti-emesis, is really nausea and vomiting. So I like to throw that word out there. So if you see it in your notes or see it in the clinic, that's nausea and vomiting. So cancer-related fatigue is another one. I don't think that one needs much introduction. That's pretty self-explanatory, and a lot of folks deal with cancer-related fatigue. Distress management, some cancer-related infections, some immune-related toxicities. This is becoming more and more popular, or more and more common, not popular, but common, because immunotherapy and immune-related treatment options are more common in the cancer center. So we're seeing these toxicities, and of course, survivorship. And these are just a few that we're gonna look at a few of these, but there are several other guidelines on the NCCN website. And I'm going to start it off by talking about symptom management. Specifically, we're going to talk about cancer-related pain. Cancer-related pain is probably number one or number two reason that I get. I think it's number one reason I get a referral to my clinic, and so it's a distressing symptom, and it's something that I feel should be managed pretty aggressively. The International Association for the Study of Pain defines it as an unpleasant sensory or emotional experience that is associated with an actual potential tissue damage. So to put this in a little bit easier terms to think about, this is a sensation or an emotion that may be associated with actual or potential injury to your body. The chronic cancer pain definition is a little bit different, but this is pain caused by the cancer itself or the spread, the metastasis or the spread, and or its treatment. Because we know that even treatment can cause some inflammation and therefore pain. Common causes include the tumor directly, surgery, radiation therapy, immunotherapy, as I mentioned earlier, and of course, stem cell transplant. Those are just a few of the causes. There are many. When we talk about diagnosing cancer pain, I tell my patients, okay, get ready. I'm about to ask a million questions. Don't get overwhelmed. But the questions help me determine what's causing the pain and what medications or what interventions may be best for addressing it. So I talk to patients about things like, if I give you a scale of 0 to 10, 10 being the most pain you could ever imagine, what would you rate your pain at? Simply, where does it hurt, right? When does it start or stop? And can you describe it? This one's probably the most important question. Can you describe it? Is it stabbing? Is it gnawing? Is it burning or throbbing? And these tell me, kind of help me decipher what type of pain we're dealing with. What makes this pain better or worse? Some people have already figured out a lot of things at home that don't work or that have not worked. And so we won't even try that again. And then, of course, is this pain interfering with your normal activity of daily living? That's important, because a little bit of pain may be tolerable, but if it starts interfering with working and eating, sleeping, spending time with your family, then that type of pain, it needs to be addressed. Treatment of cancer-related pain. So for starters, really, we want to focus on the source of the pain. So we need to determine, is this surgery related or radiation? Could it be chemotherapy potentially that could help? Could steroids help? Managing with medications such as the non-opioids, things like Tylenol, things like ibuprofen, some atypical antidepressants. There are several things that we can manage with medications. And then, of course, the opioid class, and people think of, I always hear someone go, oh, that's straight to morphine, right? Well, we have other options too, but that is in the opioid class. And then, of course, things that don't get thought about as much, but I think are very important. These are the pain interventions, and we have colleagues here that are interventional pain specialists that do a great job at nerve blocks, simple spinal injections, radio frequency ablation, where we actually ablate nerves. There are even pain pumps that can be put in and give the pain medicine directly at the source of the nerve roots. So these can be very helpful. And they can also prevent or keep us from having to use, I guess I should say, more medications. And sometimes I've actually found that just changing the perception of pain for folks is really helpful. Meditation, acupuncture, yoga, exercise and massage, and boy, one of the biggest ones that I see a lot is distraction. Right, I have several patients that tell me if I can just get back to work and focus on my job, it really helps me kind of forget about the symptoms. But if I'm sitting at home, and of course COVID has only made this worse, right? So if we're sitting at home, we start thinking about or noticing these symptoms a lot more. The next topic I want to bring up is another important topic, and that's cancer-related fatigue. This is right up there with pain in terms of how common it is that I see this. So this is defined as a persistent subjective sense of physical, emotional, and or cognitive exhaustion related to the cancer treatments, cancer or the cancer treatments. I think that should say cancer or cancer treatments. I think it should also be noted that it's not proportional to recent activities. So this isn't after you ran a 5 or a 10K. This is, after you've been resting and you're still very fatigued. And this is the amount of fatigue that when it becomes pathologic, if you will, is when it starts interfering with the normal functioning of folks. So we have to evaluate it. We have to dig a little bit deeper. Again, here's my million questions that I ask, but we have to figure out, is this fatigue related to potentially low blood counts or anemia? Is the pain causing you to be fatigued, or the pain medicine actually? Nutritional imbalances, and of course depression, insomnia. The list is quite long of what can cause fatigue. So we have to kind of go through and cross off everything that we could easily correct, like pain or anemia or some of those things. And then we have to start focusing on the ones that, may be a little more difficult. So a detailed fatigue history is important. And I encourage my patients to keep a journal if they can, actually. I think keeping a journal is very helpful for your clinician. And noting, what makes you really tired, or what time of the day are you tired, and what were you doing? Is it simply going to the bathroom, or is it after you went to the, after you went out and did some shopping, or what was it that really tired you out? So then we start focusing on what are the treatment options for the cancer-related fatigue. And there are several approaches to cancer-related fatigue. Of course, there are non-pharmacologic, which means that we don't use medications, or we typically use other means. So exercise and yoga, believe it or not, have the best evidence, multiple clinical trials that show that exercise and yoga or yoga can be quite helpful for fatigue. And of course, we have to a little bit of caution here that if folks have bone metastases or anemia or an active infection or low platelets, we have to be a little bit careful with exercise. I'm not saying we can't do it, we just have to be a little more careful. Of course, a nutrition consultation can be also helpful for not getting the amount of calories in. And then maybe even cognitive behavioral therapy. So some counseling or CBT can be beneficial for folks. Move on to the drugs next. So there are some drugs that can be of benefit for folks with cancer-related fatigue. Their small amount, their evidence, I guess I should say, in clinical trials has been mixed, meaning some positive, some not as positive. And of course, all of these medications do have side effects. So if we can get away with a non-pharmacologic approach, we prefer to do it. But if we can't, and we have to move on towards medications, then sometimes we use a short course of steroids. Sometimes we use stimulants, so like a stronger cup of coffee almost, right? And then there are some atypical antidepressants that may be helpful. And then if insomnia is part of the reason why we're having issues with fatigue, then we use sleep aids. And also, as I mentioned in the slide, the previous slide, sometimes cognitive behavioral therapy can be really helpful for insomnia. Let's talk a little bit about nausea and vomiting next. So nausea and vomiting is quite common, typically caused by chemotherapy, although it can be caused by radiation and sometimes even the cancer itself. I didn't get into nausea and vomiting very detailed during this talk because it's complicated depending on the cause, and so but I just wanted to give a little bit of an overview. But it typically, these are distinct symptoms, but they present together, and we try to abort if we can in the nausea phase so that people don't end up vomiting. But they're quite common symptoms. You can see up to 68% of patients can have nausea and vomiting with advanced illness. And there are a couple of ways that we go about treating. There's a preventative versus abortive, and I'll explain what that means. So we can use an approach where we try to prevent nausea from ever happening, or we give a medication and we say, when you start having nausea, then you take it. That's more of an abortive therapy. And so those are two different approaches. A lot of times when we give chemotherapy to patients, we're looking at a preventative approach. We're giving them medication at the same time that we're giving them chemo to prevent the nausea. But once they get home, they may have to use their abortive therapy when or if the nausea starts to pick up. That's really all I'm going to talk about in terms of nausea and vomiting, because like I said, it's a complex topic and we could go down a lot of different paths with it, but there are ways to control it. And luckily, the science has advanced a great deal in the last 20 years with nausea and vomiting, and I would say we do a fairly good job of controlling it with patients undergoing treatment nowadays. Weight loss and decreased appetite. I think this is something that is quite distressing for folks. I know I'm born and raised, you guys probably couldn't tell this, born and raised in Georgia. So, everything is focused around the meal, whether it be the holidays or what have you. So a decreased appetite and weight loss is something that's quite distressing for folks. And you may hear it referred to as cancer anorexia cachexia syndrome. And what our fancy way of stating it is basically the anorexia is a loss of appetite. And just not all patients with the loss of appetite have cachexia, but cachexia is a state in which the body is using up a lot of energy, a catabolic state. And so the body's using up a lot of energy and therefore getting its energy from fat on your body. And then if it doesn't get enough, it'll move on to muscle. So folks with cancer can lose weight pretty quickly. And so this is a syndrome, if you will, that we have to address as well. First, we talk about addressing things that could interfere with just the process of eating. So maybe the appetite's not that low, but eating is a chore, right? Eating becomes difficult, and that can be altered taste, very common with chemotherapy and radiation. People have taste disturbances, metallic taste, or a salty taste. So that's very common. Dry mouth Another common issue, mostly related to some of the medications we give, nausea medicines, pain medicines, all cause dry mouth. Nausea and vomiting, which we just discussed, and of course pain, and mucositis, which is the inflammation in the lining of your mouth. A lot of you may have had canker sores before, and this is something very similar, but it's more widespread in the mouth. And so we have to address that, right? And then, of course, medications can be used to try to stimulate the appetite. Megace is a drug, megestrol, which is somewhat of a hormonal type way of trying to induce the appetite. Steroids can be quite helpful. Marinol, which is a THC derivative, so we think about medical marijuana. It's not medical marijuana, but it's a THC derivative that physicians can prescribe. And then there are a few atypical antidepressants that can be a little bit helpful with stimulating the appetite. We'll move on to insomnia or sleep-wake disturbances. This is another important topic, and we see it a great deal in folks with cancer. And this can either be insomnia or daytime sedation, and sometimes both. So I think it's important to first look at other causes. This is a common theme, right? You guys have heard me already say this a few times with different slides. So we have to look and make sure we're not missing something else: sleep apnea, restless legs, pain, anxiety. But once we've ruled those things out, we can actually start moving on to possible treatment options. And cognitive behavioral therapy can be helpful. It's a good way to try to relax people. There are techniques that can be used to try to help people with insomnia. And then if we have to, we will move on to medications. There are some in the benzodiazepine class, and people think of medications like Ativan, and one similar to benzodiazepines, Ambien. And then there are some antipsychotics, which kind of sounds a little bit scary, but at low doses can be used to help get people to sleep. And then there are some antidepressants that are a little more sedating, and therefore can help people fall asleep a little quicker. So we're going to transition next into social support, which is a little bit different than symptom management. And by the way, this was not a comprehensive look at symptoms. I just tried to pick the most common ones that I see in clinic. And so I tried to address the ones that are going to pop up the most. But I wanted to also touch on a few other topics during this talk, and social support is a big one. So when I see a patient, symptoms are high on the list, but I also talk to them about how they're coping and adjusting to their illness, right? I hear a lot of times, "Doc, I'm depressed." And I'll say, "Well, were you depressed before your diagnosis?" "Well, no, I was doing pretty well. I'm depressed now that I have the diagnosis." And I said, "Well, there's a little bit of difference. I think that's more of an adjustment." Sometimes even would call it acute grief. You're grieving your prior state of health, or grieving where things are going with your treatments. So, but I try to assess for coping and adjustment to illness. Safety is important. Financial resources. Ms. Murad mentioned a little earlier, there's going to be another webinar about the financial aspects. So that might be something to tune into. Cultural specific needs, caregiver availability. This is a big one, right? And boy, has this been difficult in the COVID pandemic, my goodness. And then of course, access to transportation. So these are all things that we may briefly touch on them, but we need to make sure that we're addressing any issues there. So what do we do about them when we do find some issues? Well, there are a few things. Counseling can be helpful, especially when we're adjusting to the diagnosis. Child life services. Sometimes I have younger adults that I see that have children, and we need some help in that regard. Art or music therapy I found to be of benefit to my patients. Integrative medicine, which includes sometimes acupuncture, massage therapy, alternative medications that can be used. And then when we think about caregivers and caregiver burnout or caregiver fatigue, we need to make sure we touch on respite care, giving them a break too, right? All important. Also, moving on to coordination of care, it's somewhat similar to social support, but this is essentially involves more of the physician, where we're trying to organize the patient's care and share this information with other participants that are involved to make sure we give the care efficiently and effective, right? So communication, I can't say that enough. Communication is key. Physicians talking to each other about patients' plan of care. And this can include transitions in their care, trying to be more proactive, not reactive to things that pop up. And then, as I said, communicating, but also sharing the knowledge. So to go a little bit deeper into this topic, we're trying to make sure that we're lining your values, goals, and preferences up with your treatment. And we want to make sure that all of your treatment or all of your treating teams or physician teams are on board as well, so that we can give you the type of care that you would want. I'm going to transition now into advanced care planning, which is a topic that you guys may have heard of, and it is essentially how do we make sure that we're supporting our patients and giving them the care that they need. It's very similar to coordination of care, but this is more of a planning process, and it should be done upstream. So essentially, we want to figure out their values, their life goals, their preferences, and what they would want done in the future, so that we can kind of look ahead and make sure those are the things that we're focused on. Advanced care planning should be proactive. It should be appropriately timed, and it should be integrated into routine care. I always try to get patients, their family members, and other healthcare providers involved if I can. And although it's not required, I do recommend that patients complete an advanced directive. And I won't delve into this a whole lot because there are some state-specific types of advanced directives. But in general, there's a living will that Mayo Clinic has, and I use this form in Florida a great deal. So this is essentially a pretty straightforward form. The back I didn't put on here, but it's just simply signatures and witness signatures. But at the top, we date it, put the patient's name, or they put their name, and then you initial by which ones you agree with. If I have a terminal condition, an end-stage condition, or if I'm in a persistent vegetative state, I do or I do not want the following things: CPR, the breathing machine, nutrition, surgery, admission to an ICU, medications that can prolong my dying process, heart pacemaker, kidney dialysis. So you can go through these forms. And then at the bottom, it's important to name someone you would want speaking for you. And they should really know your wishes and basically be your voice, right? They're not speaking about their wishes, they're speaking about yours and just being your voice. So I think this is an important form. I think a lot of people feel that this is a form for folks that have advanced illness or that are older. But I think COVID, unfortunately, COVID has shown us that this is an important topic. We should be talking about this early on. So I encourage all young adults, middle age and older, we should all have an advanced directive, so that our family members don't have to guess what we would want if need be. So with that, we're going to start wrapping things up. And so I just wanted to give kind of this is an overview of palliative care, and specifically supportive care and supportive oncology. But there are a few big big organizations, including the American Cancer Society and the American Society of Clinical Oncology, that recommend early involvement of palliative care for patients with advanced cancer or symptoms related to their illness. So some of the bigger organizations are catching on to the fact that, you know, this really should be a focus for folks, and it should be in their care plan early. Of course, as I mentioned in the talk, palliative care provides additional support, aggressive symptom management. I like to note to my patients that this is only additive. We're not taking anything away from what their oncology team is going to provide. We only add to it. And so they not to take away from the standard cancer care. And then the last point, which I just mentioned a couple of slides earlier, being the advanced care planning. This helps us ensure that you're receiving the care that is consistent with your preferences. So I encourage everyone to do those if they have not done so. And your physicians can help you with this. Sometimes folks get their lawyer to help them with this, but it's an important topic. So that concludes my talk. I think we're going to move on to some question and answers. And I'd be happy to take what we've got here.
Yeah, thank you so much for your presentation. That was great information. Here in our Cancer Education Center in Rochester, and there are other locations and other Mayo Clinic sites, we have information on palliative care. And so great topic to talk about. If people have questions, we will please type them in the chat, and we will ask Dr. Taylor any of your questions that you have related to this topic. One question that I had, and you talked about it in the beginning of your presentation too, was just differentiating between palliative care and hospice. I think that's great because often people think of those terms interchangeably. And so one question that I had was and you kind of alluded to this too, is that, so when someone's seeing their oncology care team, can someone just ask for their care team to ask for a consult with palliative care? How does that work?
Yeah, so I think that that's exactly one way that it can be brought up, and I get that consult almost on a weekly basis, and that the patient requested it. But if they're explaining to their physician some of the symptoms or some of the issues that they're having, hopefully that will prompt the physician, to put in the referral. But if not, I do encourage folks to be proactive and ask their team. You know, I think that, or just ask them outright, do you think palliative care could help me right now with where I'm at with things? And so most physicians are on board to definitely get the referral going. Yep, good question.
Yeah, that was another question that I had too, because I've read articles where, sometimes because there's this misunderstanding, are there some care teams that, maybe just have a misunderstanding and not thinking that it's appropriate consult to do or anything like that? I don't know.
Absolutely. And we, just as I'm giving this talk and educating patients about the difference between hospice and palliative care, we do it all the time amongst colleagues, because it's a fairly new field, right? And it's not as old as cardiology or oncology itself, or some of the more established ones. So we have to kind of explain what we do, and we have to make sure that the care teams feel comfortable with what we're doing, right? I think we've all heard as physicians, that doctor thinks that palliative care means hospice, so he doesn't want to refer patients. So we have to make sure we kind of debunk some of those myths. Definitely.
No, good. I'm glad you talked a little bit about that. Thank you. Yeah. So we do have a question in the chat. So it says, can you prescribe medical marijuana to get edibles before getting on other types of medications? That was one question that somebody had.
Yeah, this is a topic that I address a lot in clinic. And so here's how I explain to patients. I do not have the ability to prescribe medical marijuana, but state-specific resources are available. Actually, in the state of Florida, patients go to floridahealth.gov and find medical marijuana providers, and they essentially give them a card. if they certify them or if they approve it, they give them a card. The card is so that they can go to a dispensary and then get medical marijuana in the form of gummies or drops or different ways to take the medical marijuana. But it's not necessarily prescribed at a dose by physicians, and because Mayo Clinic being multi-site, we have not been involved in approving medical marijuana cards.
Yeah, if people too want more information too on that topic, we do have a webinar that was recorded on Mayo Clinic Connect. I put that in the chat, so you can refer to that. And if you click on our More tab, that we do have a video library link that brings you to all the recorded sessions. So one of our integrative medicine physicians, Dr. DeAndre, did do a session on that. And just exactly what you're saying, it seems that it is very site specific and state specific what physicians are able to do and things like that. So that's one thing to find out more on that. Thank you. So one other question too that we got was, they're not sure if Medicare pays for palliative care. Can you talk a little bit about that?
Absolutely. So Medicare will pay for palliative care the same way that they would pay for any subspecialty referral. So if you were to get a referral to cardiology, endocrinology, pulmonology, it's going to pay for it the same exact way. There may be a copay for the clinic visit, that sort of thing, but it's going to cover it just like it would cover any other subspecialty. Whereas, as I mentioned earlier, the hospice benefit, which is totally different, and that's completely covered by most insurances, and definitely Medicare, Medicaid.
Okay, good. Thank you. And there's another question. So just asking about any support groups within Mayo Clinic that help those with advanced care. If so, how do we find one of them? I can speak real quickly just on our Mayo Clinic Connect. Again, on our classes resources tab, we do have a link if you scroll down to different support groups. And a lot of them, which is nice with COVID, I would say one thing that's good about COVID is we've realized we can do a lot of things virtually. But I can find out specifically, delve into that if there's a specific support group. I don't know too, Dr. Taylor, if you know of different support groups, and I see Megan even popping on too. She's another one of our educators.
Well, I just was looking through Connect to
Thank
see
you.
if there's anything that has advanced, and there isn't. They're more disease type based support groups. So I don't know if something like that exists someplace else, but we don't have it on Mayo Clinic Connect. And I don't know, Dr. Taylor, if you know anything more about that or not, but
it is typically disease specific. You're right. And that's what I've seen here. So we have, a myeloma support group. We have a cholangiocarcinoma support group. And I actually sometimes jump on these webinars or these support groups. I did one for the cholangiocarcinoma group most recently, and I just kind of jumped on for 10 or 15 minutes and introduced myself. But a lot of these are patient driven, right? Sometimes you have a patient that really is interested in starting these. And so I think they're tremendously helpful for folks. Actually, I sometimes say they get more out of the webinars than they do out of our clinic visits, to be honest with you. So hearing from others that are dealing with something similar is important. Unfortunately, we had more on-site, we used to do coffee with caregivers. We had a lot of different on-site things, and COVID kind of put a little bit of a damper on that, but we're doing more webinars or virtual.
Yeah, one thing I would even say, there's a general cancer group that is on Mayo Clinic Connect. And even if you just want to even post something in our education group or that general cancer group, you can certainly even just pose, are there people in this group that are with advanced cancer? And a lot of people join in, and that's a great way. I mean, that's why it's called Mayo Clinic Connect, because it's really a great way to connect and talk with each other on different topics. So no, great question. One other question, they were just wondering with your team, Dr. Taylor, how many people are on your team there?
That's a good question. So, and it's different. I didn't delve into that because of the site's specific, but I trained at Rochester, so I know kind of the team there. And then now I'm here at Florida. So here at Florida, we have 3 full-time physicians. One's a neurologist, one is a family physician, and then myself being oncology. We have 3 advanced practice providers, or APPs, either nurse practitioners or physician assistant. We have a chaplain, we have a social worker, and we have RN support as well. So there are a lot of spokes on the wheel, and we need that team to kind of, as I said earlier, to look at the whole person approach. And so I'll say first and foremost, I'm not the best person to really get into spiritual care, but I can get you to the right person. That's what I try to do, is make sure I can get you to the right person.
Yeah, that team approach is really a great way to get you to the right person. Exactly. Great. No. So just a follow-up question is, but who sees patient appointments? I think that's kind of what you were saying. Any of those team members would see patients based on what their needs are. Yeah. Okay.
That's right. All of those people that I just mentioned have clinic space, if you will. So they can see folks in the clinic, they can see them in the hospital. We're doing a lot virtually now. And so one caveat to that, in Florida, and I don't know Minnesota and Arizona and some of the other sites, but in Florida, we have to still see people face to face for pain medicine. But there's still a lot that can be done over Zoom that benefits folks. So if you need to talk to the social worker, that can be easily set up, and you can do it from your cell phone at home, right? So it's very convenient.
No, that's great. Good. Yeah, I just wanted to also mention a comment. So it looks like someone from Mayo in Florida said that these, just to kind of follow back up with the support groups, that in Florida in Mayo, and again, these may be done virtually too, depending on the group. They're facilitated by oncology social work team. So just wanted to mention that too. So like I said, you can find out actually Megan supports, puts all a lot of those support groups on the events page, which Megan, if you could maybe even put that events page
Sure.
link in the
I can drop
chat.
that in the chat. Yep.
Yeah, that would be great. But like I said, too, you can also find it on our resources tab under classes and resources. So yeah. Any other questions? I'm wondering, any last minute questions? The other thing too that I thought was great was touching on that cancer-related fatigue. That's something that we see patients here in our cancer education center. So we have a cancer-related fatigue class that we do because that is one of the most common side effects of treatment, all kinds of treatment. So just to point out too that a lot of different ways with exercise, yoga, can really help with that. And I like that idea of journaling too. That's really great to even just see if you can see trends in how you're feeling, because can you alter your activities based on the fatigue? So and yes, somebody did ask, the fatigue class is by Zoom or done virtually. So if you go to our classes and resources tab, you can find all that information on in-person or virtual or online sessions. So
and I'm I'm going to piggyback on what you just were mentioning, Angie, and I dropped it into the chat. So we do have a tab on our cancer education blog specifically to managing fatigue. We did a previous webinar on cancer-related fatigue, and that recording is housed there, so you could watch that recording. And then there's links to some print material and other videos as well underneath the managing fatigue, because it is definitely a real and big side effect that patients experience. So you could do it either as a class over Zoom, or you can look at those resources that are housed on our page there.
Thank you, Megan.
such a big topic. We could talk probably the rest of the afternoon about
Yeah.
cancer-related fatigue.
Most definitely.
So I'm glad you guys have a webinar on it. That's great.
Yeah. Yeah. And we were mentioning too, that, you know, we will post, and actually now that Megan mentions that, a lot of that information on fatigue is on there, but we will also post some resources on palliative care too, along with the video, this recording of the video. And again, if people joined in a little bit later, I did mention in the beginning, it takes us about 3 days to get the recording edited and then put back on Connect for people to view again or view at a different time. So yeah. So any last questions? I don't see any other questions, but great topic. We appreciate so much your time, of you spending time with us this afternoon, Dr. Taylor. We really appreciate it. So
Thank you so much for the invite. I enjoyed chatting with you guys. This is near and dear to my heart. So thank you.
yeah, thanks. So thank you, everyone. I hope you have a great afternoon. And if you want to watch again later, we will have the video on in about 3 days. Thanks. Bye-bye.